Ms. Azar, nice to see you. Enjoyed our conversation yesterday, thank you. I'm a physician. I've worked in the public hospital system of Louisiana, taking care of the uninsured and the poorly insured, which is to say Medicaid patients. Now, there's a lot of data out there that patients covered through Medicaid oftentimes have worse outcomes than those who are covered through other forms of insurance, even when correcting for disease burden and socioeconomic factors. Clearly, we should have a bipartisan interest in having outcomes data that shows who's doing a good job and who's not. And if someone's doing a good job, reward it, and if they're not, figure out why and trying to improve it. Fair statement?
I couldn't agree more.
Any thoughts about the data sets that are currently available? I'm told that for Medicaid and CHIP, right now there is, in theory, a structure for this outcomes data to be accumulated and compared, but in practice it is not. Thoughts on that?
I do not know the data sets, Senator, but if confirmed, I will gladly look into that, because I do agree we ought to always be evaluating our programs to see what works, what doesn't work. Are there certain programs that work better than others? Because our goal is that people have affordable care, they have access to care, and if one approach is better than the other in delivering quality for that, we ought to be using any data we have to find that.
Now, yesterday you were opening meeting informally with senators from both sides to go over certain issues. I would just ask at some point, because our ranking member and chair have been very good about convening that, what can we do as a federal government to have better data sets so that patient outcomes can be monitored? Because it's an old maxim of healthcare, if you don't measure it, it doesn't improve.
Yep.
And I think we need to measure that.
Yep, and Senator, I appreciate your invitation in the event that I'm confirmed to any kind of convened bipartisan process to work through these difficult issues. I hope that if I am confirmed, I hope what you will find is that my style is one, I don't believe I've got the answer to every problem. These are complex and vexing issues, and I want to have an open dialogue back and forth. I'm a problem solver. My brand is that you know, if there's a program that's not working, if it can be made better, I want to work on solving that problem, and I want to get the best input and the best ideas from the board of directors.
Well, from our perspective, if there's something you can do administratively, we don't have to mess with it. But if there's something that you need legislatively, then we should devote our attention, and that would be the purpose of this.
But I'd also appreciate the ideas. If there are ideas about what can be done administratively, I would want those ideas also if confirmed.
Then let me have some ideas from you right now. Public health, there's been a problem. I was working with Senator Schatz and some others as regards how to have a public health fund. So if we get another Zika, it doesn't take a special appropriation, just to give you a kind of my thoughts on that. And I compare it to under Katrina, Congress had to come in and appropriate money for FEMA to go and respond to Katrina, and now we figured out, no, or before I came in, they figured out, no, let's just put the money up front so that they can immediately draw down. From my perspective, we should be doing that for public health as well. But what thoughts do you have as regards how we can help you better respond to public health emergencies?
Well, I was actually back in the Bush administration, one of the architects around Project BioShield. So I really see in preparing for public health emergency and response the benefit of having predictable funding and the ability for the government to be a reliable partner in that development process. So I'd be very happy to work with you. Obviously, I can't speak for the administration, but I personally.
How do you safeguard from the money being frittered away on things which are not public health emergencies are being used as a slush fund to cover shortages elsewhere?
One would have to draw the lines very clear. I would share that concern. You would need to make sure it's really built into a development or response program for public health emergencies like a Zika, like an Ebola, or frankly, as we have with the countermeasures development programs.
Now, let me also say, and this may just be something to encourage that you monitor. Sheldon Whitehouse and I always have to say Sheldon. If I say White House, they think 1300 Pennsylvania Avenue. So Sheldon Whitehouse and I, in the 21st Century Cures Bill, put forward something for health IT. And my physician colleagues just are retiring at age 55 because they're just sick of electronic medical records and the dampening that has been upon their ability to interact as well as their productivity. So in the 21st Century Cures, the Health IT Act was included that gave some directives. Supposedly it's progressing well, but nonetheless, trust but verify. Any thoughts about that and how we can ensure that health IT actually becomes an enabler of patient-physician relationships as opposed to an impediment?
I need to be careful here because my father, Dr. Alex Azar, may jump to the table here and start telling you about all the problems of exactly the problems you're talking about.
I'm with you, brother.
I think that when Secretary Leavitt was secretary, and we went down started the journey on health IT, he was adamant. Electrification of health records without interoperability is not useful. That's just moving files to a different place. And I'm afraid we've done a bit of that, where we've electrified our record systems, but we haven't gotten interoperability. We have made it too complex at the point of entry with the doctor. So I would love to work with this committee, and I certainly will, if I'm confirmed, will work within HHS to drive towards interoperability and reducing physician burden, because it should be an enabler, not something that detracts. The doctor's eyes should be on the patient, not on the computer screen.
Fantastic. Amen, brother. And I yield back.